Hi, my name is Carleen Morgan, and today I'll be discussing my presentation on maternity care for women with morbid obesity. So this is the table of contents that we'll be discussing throughout today's presentation. What is obesity? So obesity is defined by the World Health Organization as an excess amount of body fat that may have adverse healthcare outcomes. In maternity care, we use body mass index. We do this as a calculation in our first booking and interview. Using our pre-pregnancy weight, and then throughout further antenatal visits we are able to calculate their BMI and monitor and track women's weight gain throughout their pregnancy. So obesity in pregnancy contributes to increased risk of illness and death for both mother and baby. Pregnant women who are obese have an increased risk of VTEs, gestational diabetes, preeclampsia, postpartum hemorrhage and wound infection. This matters as midwives, as we aim to guide and educate women to become healthier versions of themselves, not only for them but for our future generations. Midwives are given the unique opportunity to screen early and intervene when it matters most. So factors that affect and maintain obesity. So stigmatism, beliefs about obesity, such as attributing to the lack of willpower, hygiene, attractiveness, often impede a woman's access to effective treatment. These negative preconceptions can also contribute to low self-esteem. Low self-worth, many women turn to food as coping mechanisms for stress, depression, and anxiety, seeking comfort in moments of loneliness and emptiness. This can lead to episodes of compulsive eating, which also just increases to those chances of increased risk of morbid obesity. Poor emotional regulation, so difficulties in their emotional management is heightened in research by Hearst are associated with binge eating episodes due to a lack of control over eating behaviours. Negative thoughts and emotions like discontent, overwhelm play a significant role in that dissatisfaction with food and overconsumption. Societal norms and cultural influences, so cultural attitudes towards food, body image and physical activity can significantly impact eating behaviours and lifestyle choices. Social networks and support, so social support from family, friends and community plays a crucial role in obesity prevention and management. Supportive social relationships can provide encouragement, accountability and practical assistance in adopting healthy lifestyles and behaviours. Peer influence and social networks, so social media platforms can influence individuals' attitudes, beliefs and behaviours. And that has been related with that so-called fat shaming, which is experiences of that stigma and discrimination based on body weight that can lead to low self-esteem, depression, anxiety and avoidance of healthcare services. And food marketing and advertising, the food environment is shaped by marketing practices that uses strategies to promote poor nutrient foods that are based high in sugar, salt and fat. These are targeted at our vulnerable populations and are increasing our obesity risk. When we look at obesity in pregnancy, so the prevalence of obesity among pregnant women in Australia is increasing, emerging as a significant public health concern. Obesity has profound implications for both maternal and fetal health, posing heightened risk that it can impact decision making. This may reduce a woman's autonomy and right to self-efficacy, respecting her choice and self-determination. And doing this, we are sometimes unable to advocate to protect the rights of that birthing woman. This pie graph demonstrates the percentage of our pregnant population from 2022 in regards to their BMI, and as we can see, we have a large range of women that are outside that normal weight. When we look at implications of obesity, so the maternal side, so I've broken it down into 4 different groups. So preconception. So obesity will affect the metabolic process in a woman's body and allow it to become more susceptible to adverse maternal outcomes. These disorders may affect placental blood flow and can have detrimental fetal outcomes. It's unfortunately, morbid obesity has a decreased rates of fertility, increased medical and obstetric import, and need for medical intervention and medication, which is recommended that obese women commence 5 milligrams of folic acid 1 month prior to pregnancy. When we look at antenatal, we look at increased frequency of antenatal appointments, increased risk of transfer into tertiary hospitals, as unfortunately these women need to be looked after by specialised medical teams that work with this high-risk population, and not all areas, particularly remote and rural, who look after those women have the ability to care for this cohort. There's increased rates of preeclampsia, gestational diabetes and pregnancy-induced hypertension, and increased rates of preterm birth. When we look at the labour and delivery side, we see high likelihood of requiring a C-section due to factors such as macrosomia and prolonged labour. We look at increased rates of postpartum hemorrhage, wound infection and VTEs. We also look at the psychosocial impacts, so morbid obese women may face stigma, body image concerns and stress during pregnancy as well. When we look at the postpartum side of things, we look at the increased risk of type 2 diabetes, the increased risk that comes along with obesity-related health issues such as hypertension, diabetes and sleep apnea can persist and worsen postpartum as well. We also look at the increased risk of long-term maternal weight gain, as postpartum periods can be extremely difficult both emotionally and physically, and women can often result back to those behaviours that we've previously discussed. When we look at the fetal implications, so we look at congenital abnormalities. So there's an increased risk of giving birth to babies with neural tube defects and heart defects, increased rates of fetal macrosomia due to the gestational diabetes. Unfortunately, there's increased rates of early neonatal death, increased rates of obesity and metabolic disorders in childhood, and there's increased rates of babies requiring NICU admissions for hypoglycemia management and respiratory distress syndromes. When we look at the social determinants of health, so we start off with access to healthcare. So morbidly obese individuals may face barriers to accessing healthcare services such as factors such as discrimination, limited availability and specialty care for obesity-related concerns and financial constraints. And that's also particularly prevalent in women in those rural and remote areas, which often means leaving their families behind to be transferred to these tertiary care settings that can look after these high-risk women. We look at the socioeconomic status, so morbid obesity is more prevalent among socioeconomically disadvantaged populations who may have limited access to resources such as nutritious food options, safe environments for physical activity and opportunities for healthcare, education and promotion. We look at employment and income. Morbid obesity can impact employment opportunities and income potential due to discrimination, physical limitation and health-related absentees. As midwives, we should be able to ensure we use services available, for example, social work or welfare officers, to see if we can provide any further assistance to these women gaining consent prior to involving these external services. Education, so limited education and health literacy can contribute to the development and management of morbid obesity. So a lack of knowledge about healthy eating habits, physical activity increases that risk of obesity throughout the future. The environment that these women live in as well, so the facilities that are available for them to maintain a healthy lifestyle, and that includes physical activity as well. And the social support, so social support from family, friends and community plays a critical role in managing morbid obesity. However, these individuals and these women may experience social stigma, discrimination and isolation, which can negatively impact their mental health, self-esteem and overall promote that negative cycle, which can increase to more weight gain. We look at food environments as well, so the access to affordable and nutritious food options is essential for maintaining a healthy weight, and morbidly obese women living in these areas that may not have access to fresh produce and healthy foods may rely on processed foods, exacerbating that obesity risk. When it comes to the barriers accessing midwifery care, so women often report feeling that discussions about their weight dominate their interactions with obstetric providers, and these express concerns that their weight affects the quality of the care they receive, from inadequate communication about individualised risk factors to unnecessary ultrasounds and blood tests. When discussing weight-related issues, including weight gain, potential outcomes, the choice in words is crucial. Many women find the term obesity stigmatizing and prefer the use of weight instead. And there's a growing evidence suggesting that women perceive their interactions with antenatal care providers as negative, judgmental and lacking in empathy. So what can be done? So Early engagement, promote access to antenatal care, enables midwives to educate women about BMI, healthy weight gain, and the risk of obesity and pregnancy from the earliest stages. This allows for goal setting and early intervention to optimise outcomes. Individualised strategies, so midwives are able to provide personalised plans that identify these women's risks and their own personal experiences. This often makes women feel supported and heard, providing that advice that is relevant, relatable, and easily incorporated into their routine. Continuity of care, so establishing continuity of care promotes healthy weight management throughout pregnancy by fostering strong interpersonal relationships, which this allows for open communication both between the women and the midwife, so to discuss conversations that may be difficult, and the woman is able to have that relationship with the midwife. Self-efficacy, so equipping women with coping mechanisms and distraction techniques to facilitate effective weight management. And we also talk about collaborative care, so involving the multidisciplinary team with consent from the women. So services that are available, we also just look at those key behaviours for weight loss. So the woman needs to be motivated and willing to make a change, and understanding the impacts on the fetus, using the SMART goals as well, something that's achievable and relevant to her, and making sure those support networks are in place. So when we look at the services for obese women, King Edward's have a Blooming Together program. So this program basically offers a range of resources and information for overweight and obese mothers to help achieve minimal, healthy weight gain throughout their pregnancy. It's developed by midwives, dietitians, and feedback from women with a BMI above 35. So its pamphlets and resources were developed to discuss calorie intake, portion control, and easily identify the information on the back of food packaging to give them the best information for making healthy choices. So the program offers 8 visits throughout the antenatal period and postpartum period, with a group-based therapy which discusses a range of physical and management strategies surrounding obesity. This program highlights that continuity of care that we discussed earlier, allowing for strong relationships to be built and developed, and sensitive issues can be discussed within a safe environment. And when we talk about the guidelines that we have for these women, so there's 3 main ones that come up. So when we talk about RANZCOG, emphasis preconception maternal health, promoting weight loss and vitamin supplementation, recommendations focus on antenatal health with strict monitoring of weight gain to optimize nutritional status, BMI, and fitness. Recognition of obesity-related complications during labour is addressed with recommendations for transfer based on BMI and local healthcare facilities. We talk about the NICE guidelines, which addresses obesity in pregnant women throughout the antenatal and postpartum periods, providing practical strategies for healthcare professionals to educate and empower women. These guidelines enhance communication with women on sensitive topics surrounding obesity and weight management. And lastly, we talk about the King Eddie's guideline, which is available for all West Australian midwives. This guideline is provided and gives recommendations for accurate BMI assessment, antenatal care, and intrapartum management, including monitoring of birthing women throughout their labour, to ensure optimal maternal and fetal outcomes. So that's the end of my presentation, and this next slide is just a list of references that I've had throughout. Thank you for listening.